We'll start with an introduction to IDDSI, and then we'll follow that with a panel discussion. After the panel discussion, we'll have a live demo that will show you what each of the levels look like. And if time permits, we'll close with a Q&A for our panelists. So let's meet our presenters. First, I would like to introduce you to Christine Busby. Christine has over 20 years of experience working in skilled nursing. She's held many roles within the long-term care industry to include therapist, facility manager, and regional director, just to name a few. She currently holds the position of Vice President of Care Management for Signature Healthcare. For our panel discussion, we'll be joined by Dusti Cameron. Dusti has been in long-term care for over 12 years and is currently a food and nutrition manager with a prestige care community in Albany, Oregon. And next, I'd like to introduce you to Mary Casper. Mary is the Corporate Rehabilitation Director for ProMedica Senior Care. She has over 33 years in healthcare, focusing on the needs of the geriatric population. She's currently volunteering with the U.S. Territories IDDSI Resource Center to support the implementation of the International Dysphagia Diet Standardization Initiative in the United States. Lynda Gluch comes to us with over 30 years of experience in long-term care. She's one of the founding members of the RD Executive Council, and she currently serves as the AVP of Clinical Support Services for ProMedica Senior Care. Next is Lindsay Lillie. Lindsay is the regional SLP mentor working for Infinity Rehab. Her role and mentorship with Infinity includes assisting Infinity's parent companies, Avamere and Prestige, in the transition and training of the IDDSI terminology, procedures, and policy. Next, Brian McGowan. He comes to us with over 30 plus years in the food service and hospitality industry. He's been with ProMedica Senior Care for the last 12 years as the Director of Food and Dining Services. After our panel, we'll be joined by Chef Dave DeBroth from Mirkovich and Associates. Chef Dave is a classically French-trained chef with over 20 years of operations experience, including 7 years in healthcare. Richard Sternard will be joining us for the Q&A. Richard is the principal from Mirkovich and Associates, which is our manufacturer representative firm for Roku. All right, so let's get started. We're going to start with Christine Busby.
Hello, everyone. I'm going to start with a brief overview, and you can go to the next slide. I'm going to do an overview of the IDDSI diet, talk a little bit about some benefits and challenges from the speech pathologist perspective, and then about the importance of the relationship between speech pathology and your dietary department. Next slide, please. So as you can see on the screen, there is a graphic of the IDDSI diet. And again, as most of you are already aware, that's the International Dysphagia Diet Standardization Initiative. And this is a global standard with terminology and definitions to describe texture-modified foods and thickened liquids used for individuals with dysphagia of all ages, in all care settings, and for all cultures. The framework consists of 8 levels, as you can see, from level 0 to level 7. And the levels are identified with text labels. They also have a number and a color, and this is used to help with increased identity of each level and to improve the safety. In the IDDSI diet, each of these levels has a standard descriptor and also a testing method, and this allows for more consistent production and easy testing of thickened liquids and the textured modified foods. So I'm going to go through some of the levels and just give you a brief description on each level. So we'll start with drinks, and that starts with white, level 0. And first is your thin liquid, and that flows like water. Next would be level 1, slightly thick, and that's a little bit thicker than water, more like an infant formula. Level 2 is mildly thick, and it pours quickly from a spoon, but slower than thin liquids. Level 3, yellow, is moderately thick, and that's moderate effort to suck through a straw. Then level 4, which can also be considered a more of a solid or food diet, is extremely thick and is eaten with a spoon. Now the food levels go from level 3 to 7. Level 3 and 4 are considered both a liquid and a food level. So level 3 is liquidized. There's no oral processing or chewing required. The patient would swallow that directly. Level 4 is pureed. It can be molded. It does hold a shape, but it does not really require chewing. Level 5 is minced and moist with visible lumps that can be squashed easily with the tongue. Level 6 is soft and bite-sized. Chewing is required before swallowing, but you would not need a knife to cut the food. And then level 7 is either easy to chew or a regular diet. So as you can see, we have quite a variety of diet levels within the IDDSI diet. And this is really a big benefit. You can go to the next slide. So as I said, one of the benefits to the IDDSI diet are the many diet levels. So there are additional diet levels over the current NDD system for speech pathologists to recommend. And this, instead of having to have a standard diet, make modifications to it, there is likely a level for every patient that is very appropriate for them. There are additional liquid levels and additional solid levels. And the descriptions are more thorough and can be addressed in several ways. So you can, as you saw in the previous graphic, there is a number, a color, and a label for each level. So level 6 is blue, and it's soft and bite-sized. Also with the IDDSI diet, one of the benefits is the testing methods are easy to use. So you can test the diet consistency and that it is standardized through methods with either a spoon or a syringe or a fork, things that are readily available in every facility setting. Now, along with all of those great benefits, there are some challenges to implementing the diet. Of course, training and education in many facilities is often a challenge. All of the dietary staff will need to be trained along with the nursing staff and the rehab staff, particularly your speech pathologist, because they are often evaluating and making diet recommendations as part of their skilled service. So there's a lot of additional training that needs to take place. Then along with that, there is the switch to understanding the different diet levels and the different nomenclature that goes along with that. And change is always hard for everyone. So learning to speak in a new language when we refer to our diets and our liquids can be a challenge. So it does take some time for facilities to switch with that. Okay, your next slide. However, even though we have those challenges, working as an interdisciplinary team can really help to lessen those. And the interdisciplinary team is key to having a successful transition to the IDDSI diet. Your dietitian and dietary department and speech pathologists need to work closely together in order to transition your residents from their current diet status, whatever that diet level is under the NDD diet, to a diet level under IDDSI. They need to work closely to make sure that that's appropriate, to make sure that the orders are in place, and also that care plans are updated in the skilled nursing facility setting. So as you can see, there are a lot of benefits and some challenges, and the panel is going to address those further. So I'm going to turn this over to Tina and to the panel discussion. Thank you.
Thank you, Christine. So if you have questions for Christine, she will be part of the Q&A at the end of the session. Next, we'll be moving to our panel discussion. So Lynda, I'd love to start with you and find out where you are in the process of starting.
Okay, well, I would have to say we are just beginning, and it's taken us 2 years to get to this point of actually rolling things out. We started with an initial awareness communication back in December of 2018. And then we thought we would split the implementation process into 2 steps, doing the drinks first, since it was a really easy change. That gave us 2019 to develop an implementation plan and get resources together for the food conversion part of the process. Our intent was to start in 2020, but of course, everything was put on pause due to the pandemic. Once our vaccination clinics were completed in early 2021, we dusted off the plan and we started up things again. So our plan was initially developed to include 3 phases. The first phase involved just a proof of concept in one center. We wanted to make sure that the resources we had put together and the thoughts we had on training would work and made sense. Phase 2, which we're currently in, involves small clusters of facilities where we could provide on-site assistance. When we're through with that phase, we'll move on to phase 3, which is going to be more of an independent process. So as I said, as of today, we are only fully implemented in 5 facilities. Rollout process is underway in another 12, and we have 140 plus skilled nursing facilities to go. We've got about 60 assisted living centers that will be rolling out after that.
Excellent. Dusti, I'd love to hear where you are in the process.
So we began IDDSI a little over a year ago. We had a company come and do like a live demo at our facility that we invited other local facilities to come and check out. And shortly after they left, we started implementing it right away. It was nice because we had our speech pathologist come to the meeting also. So she was able to get a feel for what we were doing, since it was new to everybody. And so we've been doing it pretty well for a while now. It took a little bit to get everybody on board, but we've had it under control for about a year now.
Wow, so you implemented during the pandemic.
Right before the pandemic hit, yeah, we started rolling everything out.
Oh my goodness, that's ambitious. So Lindsay, tell me a little bit about the process of your communities.
Sure. So I've been working at the corporate level with a couple of companies to try and begin this transition. And so one of the first companies that started using this was Avamere, and they implemented in both skilled nursing and their assisted living facilities. And so they've actually been, they started well before the pandemic. So they've been up and running for several years now. And then the prestige buildings I've been helping with, we're in a process of, some have been implemented for a year or more, and then some are still in the process of training and haven't, because of the pandemic, in many cases, it was kind of put on pause, and so they haven't fully implemented yet, but they're in the beginning stages.
Excellent, thank you. So IDDSI isn't mandatory. So Dusti, I'd love to hear what your motivation was to move forward. And then again, I'm also going to ask Lindsay and Lynda those same questions.
So with us, it was something that corporate really wanted us to do. They didn't have a timeline necessarily as to like when we had to have it all implemented by, when they first kind of started talking about it. And I just kind of thought that it was going to be easier to just roll right after the training. It was fresh in everybody's mind, rather than having the training and waiting a year to try to implement what we learned way back then. So yeah, that's why we started. Then I think it's great.
Excellent. And Lindsay.
Yeah, there's so many benefits to IDDSI. One being that IDDSI is going to be international. It is international. And this is the first time that there's a diet that has motivation traction to actually be utilized worldwide. And the benefits to that are amazing. The fact that, not only locally in our community will we be able to communicate with our hospitals and the skilled nursing and the assisted living, and we'll all be able to use the same terminology, but we'll actually be able to communicate worldwide using the same terminology. And we'll be able to share research worldwide because we'll be using the same diet levels. Previously the diet levels were, it wasn't well defined, which IDDSI is very, very specifically and clearly defined. And that's one of the benefits. And the names were inconsistent previously, whereas now it's just under one terminology. So yes, there's going to be some hiccups moving toward that. But I mean, in the long run, once we all start using this, it's really going to help reduce a lot of the confusion and questions. And then not to mention the fact that this is the first time that ASHA, the American Speech and Hearing Association, has actually embraced a specific diet label. They never embraced or approved or put their stamp on the NDD, the National Dysphagia Diet, or any of the other previous diets that have been out there. This is the first one because it's so specific and standardized, and it's based on research. The different levels and what it means and why they're using it. That this is something that ASHA has finally actually endorsed. So that's why we're really excited about it and embracing it as well.
Excellent. And Lynda, tell me about your situation.
Well, motivation might have been a strong word. We really, we struggled initially to kind of get our thoughts together on how we were going to get our arms around this and move forward. And I would say the most compelling reason we had that got us going would be that we started to admit residents that are inpatients that were coming to us from hospital systems that had converted. So they came to us, and then we had to figure out what to do. And these were, nationally known health systems, including the University of Michigan Medical Center here in Ann Arbor, Johns Hopkins out in Baltimore, and then, of course, ProMedica Health System, of which we're a part, had converted. And we were on the strategic planning team for that. Of course, implementing in an acute care setting is a very different model than in skilled nursing and assisted living. So we had to figure out the best way to go, but we knew we had to do it. Now, I'll say that before we got started, you would talk to dietitians at the center level who would say, yeah, we did get a patient that came in and they were on minced and moist or soft and bite-sized. Now it's much more common. Almost every center that you talk to, it's occurred, even in smaller regional areas. So we knew we really had to get moving on it. That was definitely the primary reason. Second is what Lindsay mentioned. It's the current standard of practice adopted by all of our professional associations representing speech therapists, registered dietitians, and certified dietary managers. So that was the second thing in the back of our mind. And of course, the third thing that everybody always asks is it a regulation? Does the state require it? And while it's not a requirement per se in our long-term care regs, we think it will be questioned by surveyors down the road. Once they start seeing IDDSI in place more commonly, our thought is that it will fall under FTAG 658, services provided meet professional standards, because the guidance for this FTAG identifies the source of standard of practice as the Academy of Nutrition and Dietetics. So those were really our motivations for moving forward on the food side of things. As I'd mentioned before, we did the drinks over a year ago, and that was a very simple, straightforward process.
Excellent. So, Lindsay, for communities that plan to implement but haven't, what are the factors that would speed up or slow down the process?
Yeah, great question. I would say one of the things you want to figure out early on is what IDDSI diet levels you're willing and able to provide at your facility. IDDSI says that you don't necessarily have to use all of the IDDSI levels. It is beneficial, and trust me, as a speech therapist, I love having all of those options. But if you're in a small facility and you have a really tiny kitchen, you may not be able to produce each and every one of those levels. So it can be really helpful to kind of sit down and say, okay, which ones are we really actually, how many are we able to do, and which ones are we going to embrace and adopt? So that's one of the things you need to figure out early on in the stage. Another thing is how you manage dual or mixed consistencies, because IDDSI, as I said, I've been working on transitioning to IDDSI for several years now. And in the beginning, when we first started embracing and adopting IDDSI, one of the things they said was that any sauces and gravies or milk on cereal or broth in the soup, it had to be extremely thick for a modified diet. Since that's changed, since they now say, well, as at the discretion of the doctor or a speech therapist or whomever has that ability to say that in your facility. So with that thought in mind, you need to figure out as you're transitioning, that hasn't been a requirement previously under our prior diets. We just assumed that if they were on thickened liquids, then the soup would need to be thickened as well, and the milk and cereal would need to be thickened. But it was always just assumed that would be to the same thickness that the liquid was ordered. But that may not be the case. Some patients may do really well with thin liquids if they're just drinking it from a cup. But when it's mixed with food, such as milk on cereal or soup and the broth in your soup, that's where they may have a really hard time managing chewing and the thin liquids. And so there may be some patients who need thickened, broth and milk in that situation, but they can drink from a cup thin just fine. So you'll need to figure out when you're in the process of transitioning from perhaps the National Dysphagia diet to the IDDSI diet, how are you going to handle those mixed consistencies? Because you may not have orders for that. So you're going to want to figure out what's going to be your process for that. So that's just something, do we need to get speech orders on every single patient? That may not be realistic. Maybe we default to what their liquid consistency currently is. And then if anybody has questions, maybe then we need to get speech orders to clarify, does it need to be thicker or what do we need? But that's one thing, consider how you're going to be managing the mixed consistencies. The other question is breads. Breads are very different on IDDSI. They're more modified. So just I would just say plan ahead and figure out, how do you want to address these things? Because those are going to be some of your biggest hurdles.
Excellent. Thank you. So Brian, I'd love to hear what concerns that you've run into with implementation.
Well, right now it's staffing. The situation with the line staff vacancies has been the biggest challenge. Food service directors, they're actually working positions. They're cooking, they're running tray line. So taking on a challenge like this, a new initiative like this, sometimes it's not possible in some certain centers. In fact, some of the centers where the staff is stable in dietary, they've been asked to help out in environmental services. So making these initiatives in some centers at this time is difficult.
Excellent. Thank you. Lindsay, do you have anything that you'd like to add?
I was just say, be prepared for diet name confusions as you're transitioning. It will get easier with experience, with practice, but in the beginning, when you're transitioning from, mechanical soft or dysphagia advanced or whatever diet label it was to soft and bite-sized or easy chew 7 or whichever, how that works, there's going to be that struggle to learn these new names. So have lots of signs up, have lots of training. I do think using the acronyms is incredibly helpful, but in the beginning, people aren't going to know those acronyms. So make sure you have the names and the acronyms. So again, that soft and bite-sized SB7 or SB6, excuse me. See, now I'm mixing it up. But you want to make sure that you have those up and available so that the more you see it and encounter it, the more it starts to click, and then you just don't even have to think about it.
So Mary, what do you perceive to be the benefit of moving forward?
Well, of course, patient safety is is a key component and consideration here. The fact that we can speak the same language across settings is going to improve patients' expectations and minimize risks. The other thing I would add is, while this wasn't a focus during our pilots and initial conversations, staff were really able to identify that residents on pureed diets might be able to take a minced and moist diet instead, which is less restrictive, and therefore, because textures that weren't available before are now included, we can look forward to a little bit more variety and less restriction on that patient's menu choices.
Excellent. Thank you. So my next question is for Brian and then Dusti. So I'd love to know what roadblocks that you've run into with staff, with residents, with other team members within the different communities.
Dusti, I'll go first. We haven't had any roadblocks as far as the interdisciplinary team in centers where we've implemented the IDDSI program. But I would say, again, the biggest roadblock in getting started is the staffing challenge that we mentioned previously. When we asked certain food service directors to participate in the pilot, some of them declined because they just weren't in a position staffing-wise to pull this off. So as we get into, Lynda mentioned the third phase of our rollout, and when we get into that phase where the center is following the plan without any assistance, it might be tough. It might be tough.
Okay, Dusti.
So I think that our really only biggest roadblock was kind of trying to figure out whether people were on texture diets because they had a swallowing issue, or if it was just because of their teeth, because of a different physical disability that they just needed their food modified for whatever reason. That was probably the biggest roadblock kind of moving forward, because when you're transitioning diets over from from the mechanical soft, from the different levels to the IDDSI, it really matters why they're on the diet. So I think that was probably our biggest obstacle moving forward, is just trying to figure out why everybody was the diet that they were on.
Absolutely. Makes sense. And so Dusti, since we're talking with you, I'd love to know, in terms of training, what did you do to specifically help the food service staff learn the IDDSI diet?
So with my stuff specifically, like I was saying before, we had a company come in and do like a live demonstration when all of this first started rolling out in Prestige. And then from there, as new stuff is hired, we just train them just like you would any other diet or any other way you would train anything in the kitchen. Just a lot of repetition. And then as far as outside of the kitchen, we didn't do a whole lot of like hands-on training, but we have everywhere, all over the building. We have flyers with different foods that are consistent with the different levels on the IDDSI diet.
Excellent. And Brian, I'd love to ask you the same question. Oh, Brian, you're muted. There you go.
There you go. Thank you. I don't know how that happened.
It's not a meeting until someone has to unmute. So.
Okay. All right. Well, we did the same thing. We did a couple videos, less than two minutes long, for our cooks, so we can show them how to actually produce the product. But in addition to that, we've role played. We used test tray tickets. The starter would call the test tray out to the cook, and believe me, that first time they heard themselves talk about minced and moist or soft and bite size, the learning experience became live. It was more than just a diet on paper, if you will. And then when the cook responded with the correct plate presentation, everybody sort of connected the dots. And so when the tray then slid down tray line where the checker would have to put on the dessert, you could see the light bulb go on for them too, because they had to pick the right texture dessert to put on that tray. So it was fun watching them learn and take a concept and make it really live, if you will. And in addition to the menu items, the staff began to expand their IDDSI thinking for the extra items that were requested by patients that they needed to put on the tray. So I can remember specifically when the one girl was saying, oh, this is an extra item. It was fruit for a soft and bite-sized diet. But the crew knew to check the liquid within that product. And sure enough, they added a little thickener so that there was no dripping from the product. So it was fun to watch them learn and really expand their knowledge to other items other than the menu items.
That's awesome. Lindsay, I'd love to hear about the same situation from your perspective.
Absolutely. I think those are great suggestions that Dusti and Brian shared. And I would just kind of add to that the benefit of training the testing methods and becoming familiar with the different IDDSI tests. The other thing, I'm a huge proponent for understanding why. If you understand why we have to have, the minced and moist, for example, why does it have to be 4 millimeters? Well, because the research says that an average person, when they chew their food, it gets ground down to 4 millimeter sized pieces of particles. So therefore, when we're saying that minced and moist has to be 4 millimeters, it's because if someone doesn't have teeth or they're having difficulty chewing, the food will already be broken down enough that they should be able to manipulate it and swallow it fairly efficiently, even if they don't have the ability to break it down to 4 millimeters themselves. So I really think that's helpful just to understand the why. So, understanding same thing with soft and bite size, the reason for the sizes and the reason for the softness. I won't go into all of the reasons, but one of them that I find really interesting is the softness having to do with, the pressure of your tongue is the same amount of pressure as it takes to blanch your thumbnail. So if you push with your thumb, that point where your thumbnail starts to blanch and turn white, that's the same amount of pressure that your tongue is exerting during the chewing act. So that's actually really helpful. If the food is soft enough that it can be modified with that amount of pressure, then that's going to be someone who may not have teeth, again, they may be able to handle that really well. And so that just it's helpful to understand that this isn't just arbitrary. This is actually meaningful. These different levels are meaningful and based in research.
Absolutely. Absolutely. So, Brian, I'd love to know what CNA education, if any, did you provide? And if beyond the CNAs and the dietary staff, is there anybody else that needs to be trained?
Yeah, we did. For the nursing assistants, we kept it short. We kept it very simple. We used the in-service describing the new names and what would look different in the foods being served, and how soft and bite-sized diet would help them not having to cut the food for residents, and why we were doing this, letting them know that hospitals in the area were sending admissions to us using these diets. But what really turned their light bulb on was when the nursing assistants, as well as administration, activities, we got everybody in the building involved to watch these test trays. And so when you see the diet ticket with the new diet, minced and moist, on it, and you see the product on the plate, that's when the light bulb goes on. See, you can see the expression in their faces again. They go, oh, okay, I get it. That's what that product will look like in the future when the minced and moist diet is being served. And then when we said, hey, if the food doesn't look like this, don't serve it. Then you could see in their eyes again, oh, we do have a responsibility, just like we always had, to serve the right textured foods. So they embraced it at that time when you actually see the product with the diet test tray.
Excellent. Thank you. Lindsay, what about in your communities?
Yeah, I would just add, I know time is always an issue, but the more people you can train, the better. And don't forget the activity directors, because they oftentimes include food in their activities. Mm-hmm. So they need to understand what the different diet textures are. They probably need to know how to do the test to make sure that the cupcakes they serve pass the test for the different diet texture, or whatever it is they're doing, the popcorn, whatever the case may be. So make sure that the whole facility, as much as you can, is at least familiar with it, but don't forget those activity directors.
Excellent. That's a great point. So there are a ton of tools on the IDDSI website. I mean, there's posters, there's an app, there's YouTube videos. Brian, I'd love to know which of those tools, if any of them, that you used and if you found them helpful. And Lindsay, same question for you.
I'll go first, Lindsay. The main resource we used from the IDDSI website was the implementation guide. However, we shortened it quite a bit. We didn't use the 12-month. We shortened it down to 6 weeks. And we used the information from the tools and resources on the website, but felt that they had to be streamlined as well and customized to our food service operation. But Mary, maybe you can tell us more about the IDDSI resource groups.
So yeah, thank you, Brian. We're aware in our company that the United States and Territories Implementation Resource Group, or USTIRG, from IDDSI began in January of 2021. And there are now resources posted under the American flag icon that are specifically relevant to the United States. So for example, the whole state and federal survey process is really unique to the United States. There are some resources that are on the general IDDSI site, like patient education handouts, patient family education handouts, but they're still in British English. So they talk about crisps and biscuits. So we found them useful, but we do want them to be Americanized, and the USTIRG group is working on that.
Excellent. Lindsay, did you have anything to add?
Yes, I would just say I really appreciated the diet audit forms that are on IDDSI. Those are great to help guide your testing and understanding what the food needs to look like. So that would be one, as well as the just the framework, the IDDSI, especially the in-depth one. I know it's a lot of paperwork, but it really helps just in that understanding what the different diet textures are.
Excellent. Thank you. So, Lynda, how have you worked with the clinical team in your community? I'd be curious to find out what you and then what Dusti found, and what was their level of involvement, starting with Lynda. You're on mute, Lynda. Sorry.
There we go.
Thank
you. So our experience is that it's really the food service director, the dietitian, and the speech therapist who are the core team that plan and are going to drive the implementation of this process. That team kept the administrator or the executive director, as well as the director of nursing, informed of what's going on. We found in some centers they may want to participate, sit in on the planning meetings, sit in on the trainings, and others, they just don't have the time. And so we felt giving them the thumbnail sketch of what was going on, what was taking place, giving them the tool they needed to introduce it into the facilities quality assurance committee sufficed. Now, I will say that we worked a little bit more closely with the director of nursing, since, as Brian mentioned, we needed to educate nursing assistants in addition to the licensed staff. So there was a little bit more involvement there. But like I think Brian said, we kept the messaging short, sweet, keep it limited to just what they need to know and visuals. And that seemed to work. I mean, keeping things brief, succinct, getting them involved whenever test meals went out on the floor. We'd quick take it around and show it to them. And just like Brian said, the light bulb went off and things seemed to go well.
That's awesome. Dusti, what about in your communities?
So really, we didn't include very many people outside of the kitchen in our planning. We, of course, needed to work with medical records to get the right terminology for all of our long-term patients who were on texture diets from their doctors. But other than with her, it was pretty much just kitchen staff that really had anything to do with this until we started rolling it out. And then there was a little bit more education with the CNAs as to kind of what they were looking for. And of course, activities was informed in a lot of the stuff because they do a lot of food related activities. But other than that, it was really just kitchen. And then speech, we contract out to a different company. And our speech therapist is amazing. She's, she wants to know all the new stuff going on and all that kind of stuff. So she's really involved. She wants to know. But a lot of stuff that she knows is stuff that she's picked up at her other communities or researched on her own. But it's nice to have somebody to kind of bounce things off of when you're questioning certain foods.
Oh, makes sense. Okay. I think I would like to find out from Mary, what do you think is the hardest thing in terms of coordination between speech therapy and dietary?
Nothing. Our therapy teams are perfect, right? Seriously, though, SLPs have participated in an interprofessional conversation with patients about patients and their prescribed diet consistencies. So we know that some patients will need a physician-ordered evaluation by the SLP, and some patients can simply be transitioned based on a recommendation of the team. So just having that conversation, keeping things open and working together is the key to success here.
Excellent. So that's Mary's viewpoint from speech therapy. Dusti, from a dietary perspective, what would you say?
My computer kind of glitched out. What were you saying?
Oh, in terms of the best thing or the hardest thing in terms of coordination with speech therapy.
So I think for us, the hardest thing is, so our speech therapist works for other companies also, not just Prestige. And Prestige has spreadsheets that they want us to follow with, every diet that we offer. And sometimes it varies with other companies. And so kind of, having to remind her that the reason we're doing it this way is because that's what corporate wants, as opposed to, yes, they probably could eat that, but we need to follow our spreadsheets. I think that's been probably the hardest thing with speech.
Okay, fair enough. Next, I'd love to ask about documentation. Lynda, I'd love to start with you.
Okay, well, I'm guessing that you mean documentation in the electronic health record. And if so, we did have to make some adjustments there in adding the IDDSI labels and nomenclature into our pick list for physicians' orders and in some other places. That was not hard to do. We have the ability to make those updates within our department. We didn't have to go to PCC for that, as well as in our electronic tray card system. So that process was easy.
Excellent. And what about menu or recipe changes? And that can be for Lynda, Dusti.
Well, I'll go first, Dusti, and just kind of tag on to what you said, in that was a way bigger challenge than what we anticipated. And we all thought, oh, this is going to be a piece of cake, no pun intended, once the IDDSI framework with specific foods was available. But we found, and I'm going to quote Mary's guidance to us on this, that we use the IDDSI framework for menu planning to the extent practical to meet our patients' and residents' needs. And we know the framework is designed to support the key principles of IDDSI and identify some foods that are allowed, foods that have to be avoided. But the food service operation in our environment differs from other care setting, and we had to make decisions for menu planning accordingly and in keeping with our commitment to providing quality patient-centered care. And a lot of this, a simple way of saying it was, and I'm not sure if it was Lindsay or Dusti that mentioned it, or even Christine in the beginning of the time, when we started putting food on paper and figured out, well, wait a minute, they used to have bread, and they were just fine. If we take that away, what's the point to that from a customer satisfaction, a quality of life perspective, and all that? So I would say the dietitians on my team, along with Mary, we made a decision on how to plan that menu, on what foods were to be served, and we went from there. Now, here at ProMedica Senior Care, we use Cisco's Impact Menu Program, and we worked very closely with the team there to add recipe information that we felt we needed to be successful. As I said, planning the menu for the mixed and moist and soft and bite-sized diets, it was definitely a challenge because the IDDSI framework just didn't address every single food item that we have on the menu. Again, we worked closely with Mary, our corporate SLP, and we made decisions. I am sure we're only live, as I said before, in 5 buildings. As we get more and more communities producing the menu, we'll learn more, and we're probably going to have to make adjustments on how we did that in the future. Something else I'll say is that with our current menu and the one we're working on right now, we included both the old national dysphagia diets that we used as well as the new IDDSI diets. However, our intent is to discontinue that once we're in 2022.
Excellent. Thank you. Dusti, what about in your community?
Yeah, like Lynda was saying, there's a lot of things that there is no outline for. And so kind of the way that we handled it was we just updated people's care plans. So if there was a specific item which they really liked, we would get together with speech or the director of nursing to have them evaluated to see if they could still continue to eat that food, even if it wasn't necessarily on our spreadsheets or exactly how the state wants to see it documented. So we just worked with them. Really, like the SB6 diet is kind of the one we struggle with the most, because on our spreadsheets, at least, it eliminates bread for them. And that was a really hard one for a lot of our SB6 diets. So we just went ahead and had them evaluated and just care planned them to be able to eat bread still.
Excellent. In terms of, was there any special labeling or color coding? Brian, I'll start with you. Are you on mute? Oh, no.
I got it. Yeah, thank you. Not for food. When we implemented the liquids back in 2018, we developed the labels that had the IDDSI standard abbreviation, the number identifier, and the color code. But for food, so far during the pilot program, the staff just wants the letters MM and SB. Excellent.
Dusti.
Yeah, we don't really have any special labeling that we do. With Cisco and Thick and Liquids, everything is color coded to IDDSI diets already. So that's been really nice. But as far as food goes, there's no special labeling we do for them.
Excellent. And Lindsay.
Yes, I mean, we use it at least like in our, in the education pamphlets, but obviously, the diet slips and things usually just print out on black and white paper. So typically names, I think, becomes the most common, but it is helpful to have, especially when you're doing the training, to kind of have the colors associated. And I would just say too, make sure you use the colors that IDDSI suggests. Those are very specific and universal. Again, trying to make sure we're standardized, and then also just keeping in mind that they selected those colors to be sensitive to those who have colorblind issues. So that's kind of one of the benefits, to make sure you're not trying to add your own colors to make it different. That can actually make it hard for someone who has red-green colorblind issues, for example.
Excellent. Excellent. Thank you so much. We have a ton of great questions we want to get to. So we're going to bring on Chef Dave and Richard Sternard to join the panel, as well as we are missing Christine, if we can bring her on also. And we'd love to get through some of these questions. Excellent. Thank you, everyone. I'm just so thrilled with all the questions that we've had. So would you recommend an SLP review all the residents on an NDD diet to determine which IDDSI diet they should have, or do you just convert all ground to minced and moist? And who's got that one?
I'm pointing at Mary.
Okay.
I'll take it. I think that we're changing products, so we're making a transition. We have to have that interprofessional conversation. We have to understand why the person was placed on a modified diet to begin with. What are the underlying problems? And then from the array of choices we have added to our array, we can make a transition. Sometimes it will come up that the speech language pathologist needs to do a physician ordered evaluation to understand more about the best match for that patient's capabilities, and the way that we'll go about making those recommendations. In our situation, we also added an option of regular with SB6 meats and regular with MM5 meats to kind of accommodate those people who were currently receiving bread but would have difficulty chewing or forming a bolus with the regular consistency meats. So I don't think that the speech pathologist has to evaluate every single person. At the same time, they can be involved in that interprofessional conversation.
We created a cheat sheet for what the diet terminology that the local hospitals, either had been using or that we were using. And we created a crosswalk for, here's what the previous diet levels are and here's what that translates to. And so we'll just kind of default transition them to that IDDSI diet. And then if we're finding that it's, doesn't seem to be appropriate, then we'll usually get speech orders at that point to try and figure out what the appropriate diet texture is.
That's exactly what we did, Lindsay. Yeah.
Mm-hmm. Well, Brian, myself, and Mary, we work in the out of the corporate office for ProMedica Senior Care, and we have approximately 160 skilled nursing facilities and approximately 60 memory care assisted living facilities. So, good question. Our task was to try to figure out how we can help others at the center level, what resources we could put together, what kind of accelerated but simplified plan we could create from the tools that were available to make this doable.
Excellent. Thank you. I was asked, one of the questions is there a deadline that IDDSI needs to be implemented? Yes, Mary.
So as of October 1st of this year, the Academy of Nutrition and Dietetics is no longer going to support any previous references to the National Dysphagia Diet. So the one and only available professionally supported standard of practice is going to be IDDSI as of October 1st. Now, does that mean that somebody's going to come in and tell you that you have to close down if you haven't implemented? No. And I think everybody should take their time and implement in a stepwise fashion, as some of us have described to you. But as of October 1, the only professionally supported standard of practice that will be available will be IDDSI.
Excellent. So It's been my understanding that IDDSI is mainly meant for swallowing issues. Is that correct? And who is most affected in the use of this diet? Hey, Lindsay.
Yes, I would say it definitely is helpful for those on dysphagia. However, it's actually really great for those, as I mentioned, people who don't have their teeth, but maybe they don't actually have dysphagia. So IDDSI actually has diet levels, such as, for example, the Easy Chew Level 7, which is a subcategory of regular. So it's regular texture, but it just means that the food needs to be soft. So that if they don't have dentures or they don't want to wear their dentures because they're uncomfortable, but they don't actually have a dysphagia disorder, they don't have problems swallowing other than the fact that they're edentulous, missing their teeth, IDDSI actually can be really helpful because it has diets for them as well. So not just swallowing. This actually can be helpful for the population who may have issues that aren't actually a true dysphagia technically.
Excellent. Thank you.
Tina, this is Lynda. I'll add on to what Lindsay mentioned. And, as we started our pilot facilities, a big part of the process was the diet order conversion. And so several times Mary and I would sit down with the staff in the facility and we go through the patient list, of everyone that was on an NDD diet and say, well, why are they on it? And I was really surprised at a number of the reasons. I mean, it wasn't just swallowing, chewing, but we had some patient preference. There were a number of different reasons. I think, and Mary had mentioned this before about some of the unintended positives that we saw right away was being able to upgrade. We didn't address this right from the get-go, but residents and patients that may be on pureed diets may be able to be successful on minced and moist. The other thing, and either Brian or Mary mentioned this, was I've been surprised how many of our residents and patients are being successful on soft and bite-sized. It's a huge help for the resident. It's a help for the staff, and it just has really been a positive thing and not as onerous as Brian and I were concerned about at first, because our testing showed that it really had to be done by hand, manually. So a little bit more involved in preparing that.
Excellent. And let's see. How has the turnover in staffing impacted the implementation of the IDDSI process? Training new staff slows down progress, excuse me. Oh.
Brian, you got this one.
Yeah, I'll take this one. I mean, yeah, you know what? It's not going to go away, though. So once you get switched over to the new IDDSI diet, when you train a new person, you're going to train them the IDDSI way instead of the old dysphagia way. So it's an issue that's not going to go away. So I guess we just better embrace it and start teaching the IDDSI way.
Excellent. And do you find that physicians are using IDDSI on diet orders?
I would say, Tina, that for those hospital systems that have converted, and Lynda mentioned a couple of them earlier, the Michigan Medical Center in Ann Arbor, Johns Hopkins in Baltimore, Christiana Care in Delaware, Swedish in Seattle. Once those hospital systems make the conversion, physicians follow along. We still have physicians that are talking about consistencies that haven't been around for 20 years, but I think generally they've adopted as the hospital system has moved forward.
Okay, what is the tag number Lynda mentioned again?
It'll make me look at my notes. It's FTAG, I believe 658, services provided meet professional standards.
And there is a reference on the IDDSI page under the American flag about regulatory oversight, and that tag is mentioned there in that document too.
Excellent, thank you. What resources are used to provide education to CNAs and nursing staff?
So one of the things that we provide as far as education goes, and we've talked about why it's so important, but Lindsay had mentioned about which levels you're going to implement. Brian has talked about staffing. With the equipment it takes to get to each one of those levels, helps you determine what pieces of equipment you need. And then, as Brian had mentioned, with the equipment, it helps reduce the training and the labor that you have, the little labor that you have, and the labor turnover that you have. To the question that you have there, for the equipment out there, there are companies such as ours that go into facilities to do these IDDSI presentations with them, to talk to them about what staffing problems are you having, what levels are you looking to achieve, and then actually bringing equipment in to show them how to get there. So as far as implementing IDDSI, we've heard everything from, not exactly sure what IDDSI is yet. I've heard it, but I don't know what it is, all the way to, yes, we've either implemented it or we're on the way to implementing it. And there's companies like ours that go in and actually not only talk IDDSI, but then show how you get to each one of those levels. So as far as education goes, there are companies out there such as ours, and your direct supply account manager can help you with that.
Okay, it says what education is needed for residents, if we can bring the whole panel back. And if we switch and start doing bread the IDDSI way, the residents will be mad. I get that. I love my bread.
So that's one of the reasons why we chose to have that option of regular with SB6 meats and regular with MM5 meats. We really wanted to acknowledge that people enjoy their bread and are not having difficulty with it. If you think about the science that Lindsay has mentioned, really we use the amylase in our saliva to break down bread. And that's something that can't be controlled for in individuals. So rather than saying bread is okay for some and not for others, I think we have to assess how people do with it and allow it or not allow it, as the case may be, based on the person's capabilities to manage it. So
excellent. Thank you. Have any of you found a company that comes into the facility and trains cooks on the production of these textures? Richard, you had your hand up.
We know I was just saying, yeah.
That you guys do. You guys do it. Sometimes you have a resident that has a combination of diet textures for their orders. Can you combine IDDSI diets? And Lindsay.
I would say that's going to depend on you. You get to decide whether your facility is able to do that. Is it too confusing? I've worked with some facilities that decided, that's so hard for our cooks. We can't do that. It just makes too much risk for mistakes. So some companies have said, you know what? No, we're going to do, you're on this diet texture until you can handle everything on the next diet texture, and then you can be upgraded. Other companies say, you know what? I want to personalize it. It's a little confusing, but let's see if we can find a system to make this work. So I would say that's up to you and your staff in your kitchen and how well you feel like you can manage it. But you absolutely can if you feel like you're able to. That's up to you. IDDSI does allow you to modify it based on what you need.
Excellent, thank you. What about snacks? Did nursing get training on testing for after hours food when Dietary wasn't in the building? Like if the resident wants a sandwich after hours?
Yep. Snacks was huge. That's a great question. And I'll kind of tag along with what Lindsay was saying. As we were making decisions and planning, we tried to always think about the patient, the resident, their perspective and balancing that with their quality of life versus the reality of customizing things. So on to snacks. That was a huge challenge because many of the food items that are typically used as snacks just aren't available for the MM and SB6 diets. So we had to work on that. And that was one of our tool. I don't know if Brian mentioned the starter kit that we had put together. One of the things they needed right away was just like that crosswalk, they needed, here's an acceptable snack list. And to compound it with some of the food supply chain issues we've been having, things like, canned soups that are smooth and creamy, and that were a challenge to get. So that is definitely something. I mean, I talked a bit about the menu, but the snack piece was a whole other thing that I think we underestimated at first.
We use premixed liquids currently from Hormel. Are you mixing all liquids? I see some head shakes and some.
Well, this is Lynda. I can say at ProMedica Senior Care, we've always used pre-thickened liquids. We only do things that a patient or resident may request that aren't available in a pre-thickened format.
Okay. Dusti, is anything different in your community?
No, we pretty much just use boxed. We do have a liquid thickener that we use for residents who want certain things we don't bring in. We mostly just bring in milks and juices. So if they wanted like iced tea or coffee, soda, anything like that, we just use a liquid thickener to make those the right consistency for them.
Do you write just MM5 for your diet order wording or spell it out as minced and moist? In the future, do you think we can use MM5 versus words for diet orders and meal tickets?
Good question.
I would say, in the beginning, especially when we're just learning the terminology, write it out just to make sure. And I would say write it out and like minced and moist, and then say MM5 in parentheses. Let's get people used to seeing that. And I think over time, you can just transition to MM5 once everybody knows the lingo. But in the beginning, to avoid mistakes, I'd write it out.
That was our experience too, Lindsay. We were a bit concerned about character limits on some of those fields in the various applications, but it ended up not being an issue in PCC as well as our trait card program. We were able to spell it out and then in parens include the abbreviation. There may be some other, I'm trying to think of some labels that we had generated where we needed to use just the abbreviation. But if you have the space, it's good to start from the get-go, putting the whole word there.
Excellent. I want to thank our panel. You all have been so knowledgeable and wonderful. And again, we thank you for your time. And I'm going to turn it over to Megan.
Wow. Well, I can only reiterate what Tina already said. First of all, thank you to all of our panelists for your expertise and your time today, but also to our attendees because you provided some really thoughtful questions for us to go through. We're grateful for you. So that wraps up everything we have for you today. If you have any questions about the things that we've discussed, you can feel free to email us at webinars@directsupply.com. That's webinars with an S at directsupply.com. I hope everybody has a great rest of your day. Thank you so much for joining us.